Good morning, everyone. I'm Larry Boris, Executive Director of the National Association of Worksite Health Centers. I want to welcome you to our webinar today on testing and contact tracing, the strategic strategy discussion related to COVID-19 and worksite centers. I'm pleased to have with us Dr. David Zeek, a partner clinical services leader at Mercer, who's one of the leading authorities in the country on worksite clinics and particularly related to COVID-19. And so I hope you enjoy the session today. If you have questions, please put them into the Q&A, or you can also, we'll go around the table for those people who are here, and it'll be I think, an interesting and valuable session for you. So David, I'll turn it over to you.
Great, thanks, Larry. I appreciate the opportunity, and thanks everybody for joining. So as Larry said, I'm a physician. I'm board certified in family medicine and in lifestyle medicine. I've spent the majority of my career in this health and productivity management space. Then it evolved to health and wellness and health and well-being. I spent actually 10 years with Lockheed Martin, largely focused on the 28 on-site health centers we had in clinical strategy and operations, but in the benefits piece as well. And I've been with Mercer now for a little over 2 years and serve as the clinical services leader. Normally, my team of great nurses and doctors and myself, we all consult on everything healthcare. And I spend, because of my passion around worksite health centers, near site, shared and on-site employer-sponsored clinics, because my passion around that, I actually spend a lot of time in that space consulting with typically the jumbo employers, but mid-market as well, in strategizing that, if it makes sense for them and how to deploy those effectively. But I have become somewhat of a COVIDologist, as you can imagine. I think a lot of us have been and have been studying the science and strategy around COVID and helping employers mitigate the impacts of COVID-19 on their workforce in operations as much as possible since, good grief, 7 months now. So it's amazing how time has flown. So we have a lot of content to go through in some, I think, interesting stuff. So this was the map that we shared 7 months ago with all of these peaks and troughs, and this is what we expect until we reach what is called containment, which largely won't be until we have an effective vaccine and a good portion of the population immunized. Hopefully we are, somewhere between 6 and 9 months out of that, or out of getting to containment. But you can see how our trend there, I've kind of drawn in this red line. This is really where we've been in the US. And I actually pulled this just this morning. So this is from our sister company, Oliver Wyman. And if you haven't looked at this tool, it's a predictive analytics tool. It's a little confusing at first. So let me just describe it a bit. So the horizontal axis is time from March through 2 weeks into the future. On the left vertical axis is the total number of cases, which corresponds to that blue line. So naturally, it won't drop because it's total number of cases, and you can see how much we have, or how high we have hit. I forget where we are now, 7.4 or something like that million. And then on the right vertical axis shows the number of daily new cases. And so this 2-week period here is where the predictive analytics comes from. And you can see it does not look pretty. And so we've kind of taken this, we had a little dip, and then we go down and up like this. So it's following the trend. We're just not reading the troughs that we were hoping to hit. Long story short, unfortunately, we are headed into a challenging time this fall. So let's talk just about primary care in general. I mentioned I'm a family practice doc, so I have family practice colleagues, and I'm part of the American Academy of Family Physicians. So I get a lot of the information, and the story for primary care is pretty challenging. I'm speaking in general, not just employer-sponsored clinics. So early on in the pandemic, primary care visits dropped by 30, 40%, depending on which article you read, and in much higher by some estimates, but I think that's where people typically settled. Seeing patients is risky, right? I mean, it requires significant change to operations. Any respiratory symptoms presents a potential patient with COVID-19. And providers had to quickly pivot around their normal operations to address all of these new challenges, separating patients and seeing patients virtually first, and managing PPE inventory, learning how to conduct telemedicine visits efficiently. It was a kind of the old west, if you will, trying to figure out how to manage. And then emergency legislation came into effect, right? Margins were already extremely thin in primary care for a number of years, over the last 10 years or so. And then when this dropped 30 to 40% of volume, the physicians were in the red, basically, primary care physicians. And so this emergency legislation came out to provide some support in several different ways. One of those was reimbursement for virtual visits. And they essentially, the legislation said, we'll just pay the same for 99213 or a regular old code that an in-person visit would typically be coded for. We'll pay the same even if it's done virtually, even if that modifier, right, the place of location says that it is virtual. So the financial challenges were, at least in some way, helped through that. But the future of primary care, so let's talk about this for a second. So we don't know what telehealth is going to reimburse down the road. We don't know if volumes will pick up to before COVID, if there's some hesitation. Now we expect, hopefully, it will continue. It's on an upward trend. It is somewhat plateaued. But I'll also mention, though, that this is taxing physicians in many different ways, not just financially, not just operationally, but emotionally as well. You can imagine how challenging it is. I mean, being a primary care provider, putting yourself on that front line day in and day out certainly presents some risk. In addition, about 25% of practicing primary care physicians are 60 or older. And disruptions like this, we're already starting to hear of physicians beginning to retire. That's 25% of the primary care physicians in the US. So needless to say, primary care is facing significant challenges in future uncertainty. And as an employer, it is an excellent time, if you don't already have one, to be considering, how do I bring in quality primary care as a foundation to what I offer in health benefits to my employees through an employer-sponsored clinic, on-site, near-site, shared. There are a variety of different models, but because there is a preponderance of data that says good primary care is foundational to supporting the health and well-being of your employees going forward and managing downstream costs, certainly a time to begin considering that if you haven't done so already, or you don't offer that already. So the expansion of virtual health, I'm sure you've all seen the headlines that, largely driven by just necessity of needing to keep distance, but also driven by legislation and advertising, et cetera. The uptick and embrace utilization of telemedicine, both on the physician side, so physicians who have never used telemedicine, 53% of physicians who have never used telemedicine are using telemedicine now. So a huge uptick in those who never had used it before. And then adoption by patients as well. So Teladoc saw a 92% increase in Q1. I think that's continued, although I think it's tapered off some now. And then 94% of consumers are willing to try at least one digital tool. That was through an early on survey. So I think we all understand this, that virtual care has been certainly fueled, or COVID has acted as a catalyst, very effective catalyst, to drive us in the world of virtual care into the future. So let's shift to Worksite Health Centers now. So Worksite Health Centers certainly have unique position and unique challenges, but largely they face the same challenges as all of the other primary care in the community. So having to pivot strategy and shift operations, right, to meet the needs of the patients and the providers and staff and the employers. So it's a little bit different, right? It's unique and challenging balancing act of meeting needs and managing risk. And we had the opportunity, I say we, my team, David Kite, who some of you I'm sure probably know, he leads our Worksite Health Center operations and strategy and program at Mercer and has for many years. So we have been in contact with a lot of the great vendors out there who just are meeting those challenges and being creative and meeting the needs. We've been very impressed with how quickly the vendors have pivoted and shifted their ability to meet the needs through changing operations. So most of these clinics too, though, saw a significant drop in utilization. I mean, as a national trend, it made sense to then start to take on virtual services as well. So we've seen huge adoption of virtual services. In addition, now that we're 7 months into this pandemic, a lot of these vendors are looking at focusing on sustainability and even expanding virtual care capabilities. We've certainly heard it from the more classic telemedicine vendors, the Teladocs, MD Lives, et cetera. But now our on-site clinic experts or vendors are bringing in new capabilities, building in new strategies, expanding scope to include coaching and PT and behavioral health and all of these other items, because we're all kind of sitting on this realization that the front door to healthcare is not only going to be to your waiting room, but also will be video, telephone, texting, et cetera. So pretty exciting time when you look at the potential for ingenuity and creativity. So let's talk about operations changing for safety. This was really impactful. So this is a procedure, if you will, that has been defined by the American Academy of Family Physicians. It's been defined by many different expert entities that said, look, this is what we should be doing to protect patients, to protect providers, and protect staff. And so just kind of walk through this. So because this is a paradigm shift. If the patient's concern is clearly non-infectious, can it be managed with a virtual visit? So they're already looking at, let's make things virtual as a front door. Can we manage this complaint, this chronic condition, or whatever it is, just as a virtual visit first? If yes, schedule a virtual visit. If no, then perform COVID-19 symptom screening. And if the patient's concern is potentially infectious, or if the patient's symptoms screening is positive for COVID-19, just schedule a visit with the doctor at an outdoor clinic or in the parking lot. And it's been amazing to see the creativity of the clinics and physicians and staff in how they're actually able to execute having this, outdoor ability to improve airflow or air circulation. So in addition, clinics and medical facilities, they have been employing impeccable precautions across all of what we know should be done. So keeping distance, wearing a mask, keep surfaces clean, wash and sanitize hands. Now I'll just make a little bit of a public service announcement that we have seen a significant drop in cancer diagnosis driven by lack of screening, as well as just lack of managing chronic care and getting preventive care. So if you haven't been to your doctor's office, it's pretty impressive how clean it is and the steps taking place. And I can give you my anecdotal experience that I felt very safe. So mitigating the spread of COVID-19, I just wanted to touch on what we know works. I think we've certainly seen plenty of examples where testing in screening in temperature taking has failed to keep out the spread of COVID-19. Now, I'm not saying you shouldn't do those things, because there's probably some value and they are reasonably simple to execute. But this is what we know works. These are the only things we know. So keeping distance is the only truly effective method. So keeping people separated, right? And I don't want to get into the distance and aerosolization and everything at this point, but physical distancing, wearing masks, we know that helps limit spread. Air ventilation, so clinics being held outdoors, that is effectively maximizing air ventilation, if you will. But if it's an indoor environment, making sure you're using MERV 13 or higher, at least to get some of the filtration down to the size that you need for droplets, and then increasing air turnover, and then cleaning, right? So cleaning services, cleaning our hands, that sort of thing. These are really the only things that we know help prevent the spread of COVID-19 effectively. Now, there are other measures that employers have been taking and are, if not already, considering taking. And these are screening questionnaires. So we have seen, anecdotally, that screening questionnaires do find some people and identify some people that might have symptoms or exposure, and you can take appropriate action. So there's certainly some value there. Temperature screening, there's probably some value as well, but I haven't seen any good reviews on kind of defining that value. And largely, it's unknown, right? Because we know asymptomatic spread is occurring. In fact, 40 to 50% of people infected with COVID-19 are in fact asymptomatic. So you're not going to be able to catch many of those if they're not running a fever. Testing employees. So we're going to get into some details around testing strategies, getting into some of the details around what testing options there are. We're also going to talk about contact tracing in more detail, but just in general, testing employees can be an effective part of a containment strategy for your workplace, but there is no known defined screening protocol that is, quote, most effective. Screening everybody once a week, screening 20% of people every 3 days, there is no great data that says, this is the best strategy to identify those cases and get them out. Now, probably more frequent is best, but that can be cost prohibitive. So we're going to talk in a little more detail around strategy and things to consider into the future here. Contact tracing. So historically, right, responsibility of public health. But as we have seen, and I'm sure if you've had cases, you may have picked up the phone, called public health, and it's very, very difficult. So the infrastructure to manage an epidemic of this size or a pandemic of this size is a significant challenge, right, for public health, and we've seen significant shortfalls in support. Therefore, employers, right, have shifted to, well, maybe I should start doing that as a strategy, because we know contact tracing works, right? It's been done for centuries for infectious disease, but it has to be done relatively effectively and quickly. So we'll talk a little bit more detail, but I'll just point out that Mercer's survey, about 47% of US employers are using existing employees to do contact tracing. And then 43% were not implementing contact tracing. And this was probably about 3 months ago, though, so that data is a little bit aged. But before we jump into some of the details, I feel the need to define and differentiate quarantine versus isolation. Why is that? These are two very important terms that commonly drive confusion in defining procedures. And the media is constantly interchangeably using these terms. So I want to make sure that you all have them correct before we move on, because when we talk about quarantine and when we talk about isolation, I want you to know exactly what we're talking about. Quarantine is when someone who has been exposed but is not sick stays away from others for the duration of the incubation period of the virus, SARS-CoV-2, that causes COVID, which is 14 days. So somebody's not sick, they've been exposed, there's potential that they have virus, but the virus can hang out and not cause any disease or replicate or anything for a period of 14 days. So within that 14 days, once you hit 14 days, nearly, not 100%, but nearly 100% of people will have become sick. So that's why quarantine is 14 days. Nobody's sick. They might get sick. That's quarantine period. Isolation. Isolation is when someone who is known or suspected, right? They've got significant symptoms, they've had an exposure, and now they're feeling sick. Isolation is those people, they go off and they hide out in a room at home. They stay away from others at home. They have, symptoms, or they've been confirmed with testing. They need to isolate themselves from everybody else at their own home to prevent spreading the virus. That period of isolation is very different than a period of quarantine. Quarantine, it's 14 days, and it has to be 14 days. That's what CDC has said, regardless of what you test. Test positive, test negative. Well, actually, if you test positive, you then fall into isolation. If you test negative in quarantine, you still should keep to that 14 days. All right, so let's get into contact tracing a little bit. This is a definite eye chart, but I was not intending for you to all kind of walk through this. I just wanted, I wanted to represent this because I actually created this workflow. I didn't make it look so nice, but I created the content for the workflow for employers because it was confusing. If you Googled or searched on CDC or anywhere else, contact tracing, all you got was public health guidance, which is wildly complex and many of it not applicable to employers. In fact, you don't want to do everything that the public health is doing for privacy reasons. So I created this strictly for employers. It's a simpler, right, or made easier procedure. You can pull the actual document there. It's still posted along with a blog that I did on contact tracing. So take a moment to write that down or take a screenshot, or Larry, I think you're sending out the deck anyways. It'll be there, but you can pull up the actual PDF document. I've heard that it's been helpful, but I'll point out just a couple of things on here though. So symptomatic employees should be isolated from work and pursue testing. So if you've got a testing procedure, great. If you've got a vendor, great. But as soon as somebody is symptomatic, don't let them hang out at work until their test comes back. Because what we're seeing is when there are significant hotspots, like there are in all over the US right now, testing gets way backlogged, and public health, doesn't get a trigger until they actually get a positive test. So as soon as somebody is symptomatic, you isolate them, and then you identify who their close contacts are. Those close contacts should be notified and quarantined before the test results come back on the employee. Why is that? Because if you wait and it takes 4 or 5 days to get a result, it takes 2 days for them to actually go to CVS and get the test, and whatever it is, whatever your procedure is, it could be days. And you could have people who are already becoming symptomatic, and we've seen this, becoming symptomatic in the workplace, and next thing you know, you've got a significant outbreak. So the trigger should be symptomatic. Aha, this person might have COVID. We're going to go get them tested. While we're awaiting test results, we're going to talk to them, find out who their close contacts were. And when we get the PCR test results back, if their symptoms are all better and there probably wasn't COVID anyways based on symptoms, we can then tell everybody, okay, false alarm, but at least we didn't have an outbreak at work. Now, if it's somebody who is significantly sick with flu-like symptoms, they might want to get testing done twice just because of the false negative potential, but that should be left up to the clinicians caring for that employee. So some important things to remember. I'm not going to read through this again. You can pull the document. This is also in that PDF. Just key things: keep information confidential. Don't share sick employee's name. We've heard anecdotal stories of this here and there. Always best not to, even though it's a small workplace, some people might know. as HR professionals, whoever's delivering the message to close contacts, don't share who the sick employee is, and keep any medical information collected as secured files, not in your HR files, not as just a general HR file. They should be secured as medical records. All right, let's dig into COVID-19 testing. So diagnostic strategies. So this reverse transcriptase PCR, RT-PCR, that is the gold standard. That's what occurs in the lab. The rapid molecular is the Abbott ID Nows, it's the Expert Express, and the Q. These are molecular PCR, essentially. It's a polymerase chain reaction type thing, but not as, I'll call it, robust as the in-lab. But we have seen at least some pretty good data here and there around these rapid molecular tests, and they seem to be pretty darn good, actually. Not quite the gold standard, up to the gold standard of reverse transcriptase PCR, but certainly pretty darn good. So the PCR and the rapid molecular tests that are point of care, and so when I say rapid, it's the device that you collect the sample, it's on site. It can be done in a doctor's office or anywhere. It needs to be done by clinicians, and then it's run. You typically get a result in 15 minutes. Those two tests identify fragments of RNA, so the SARS-CoV-2 virus, right? So it identifies that, but does not identify viable virus. So you've probably heard that weeks out, people can still be testing positive, even though they're just shedding viral fragments, because these tests are quite sensitive and they're picking up on those viral fragments. So speaking of sensitive and specificity, so sensitivity and specificity are commonly described as test accuracy. The gold standard PCR in-lab test is very high in specificity and pretty darn high in sensitivity. Sensitivity is relative, or I should say false negatives are relative to sensitivity. So if the virus is there, how sensitive is it, or how easily will it pick up? And if it's not very sensitive, you'll get false negatives. In other words, the virus is there, but test comes back negative because it just wasn't sensitive enough to pick it up. Sensitivity is pretty darn good. It probably hovers around 20% or so false negative rate. This is in reality. So it ties to sample collection, how the sample is run, even though the in-lab report of sensitivity says, well, our test is 98% sensitive. That is in perfect world, right? And that doesn't happen in practice. So there are many other factors. And what we've seen is that procedure is actually very good, though, with about a 20% false negative rate. In some instances, probably a little less. In some instances, a little bit more. The rapid molecular tests probably aren't quite as good in sensitivity. And I have heard conflicting stories from hospital systems and others that these molecular tests are great, or they're bad and they have poor sensitivity, and I've not yet kind of wrapped my head around that. I would still feel pretty darn confident, though, in the results of the Abbott ID, the Expert Express, the Q, etc. But realizing you still may get some false negatives. There is a chance of false positives as well, meaning that the test comes back positive, yet there is no virus present. This is much less common, probably less common with the in-lab PCR, a little more common with rapid molecular. It probably has to do more with collection of sample, how the sample is run, that sort of thing, than a true flaw in the test itself. But the concerning thing is if there is a little bit of room for false positives in some of these assays, like we know there are, when your expected result is less likely to be positive. In other words, if prevalence is really, really low, right? less than 0.5% of the population has it, and you're getting very few positives, your chance of having a false positive is significantly higher. So anyways, both tests, so rapid molecular and PCR, are very good as diagnostic tools. Let's talk about rapid antigen for a minute here. So rapid antigen is quickly gaining attention for a variety of reasons. one, cost, and two, how quickly it can be done. The Abbott Binax Now, for example, highly reported, I guess, in the media, is a great test in that it is inexpensive. It runs on a lateral flow immunoassay. So it is a like a pregnancy test or like a rapid flu, right? In the doctor's office, you put the swab in, it runs across this lateral flow, and it has basically have antibodies that are on this this matrix, and the antigens are flowing in. And if the antigens are there, right? So the proteins that make up the unique proteins that make up the SARS-CoV-2 virus, which are typically those spike proteins on the surface, that it's picking those up. So it's easy to do, requires no very little equipment. Now, some of these other ones, like the Becton and the Codell, actually do require a little machine that looks, like a toaster, basically. Some of them require those extra machines, but the functionality is essentially the same, or the technique is essentially the same. So rapidity of results, some of these can get results, in the technology, potentially within 5-10 minutes, 15 minutes. So really, really quick turnaround, inexpensive. The Abbott Binax Now, I think the wholesale price is $5. I'll just mention the Abbott Binax Now. We're so excited about this. We met with Abbott, my team did, and they coined it Abbott Binax later because the government bought them all up and production just isn't there. So hoping, though, to see this commercially available. If anybody's from Abbott, I don't mean to bash the product. It's awesome. We're just super excited to see it. But just because of production and demand, we probably won't see it available in the general public until first quarter next year. But really excited to see that. And we'll talk a little bit about how and why that test is great. So let's talk about rapid antigen testing accuracy, though, sensitivity and specificity. So Cochrane Review, if any of you read Cochrane Review or track that, it's a group that does basically they scrub data out there for best evidence and information. And I can tell you that the antigen test didn't fare well in their assessment. They looked worldwide, and this was, I think, a couple of months ago now. So none of the tests actually listed here were looked at in that review. But antigen testing as a whole didn't fare so good around sensitivity. It was quite specific. With all that being said, though, antigen testing certainly has a place in screening populations. And by screening populations, I mean if I'm, it's quick, it's easy. You can screen populations before they become symptomatic, or when they're asymptomatic, you can pull those out. And if you miss some, you probably will. You're getting the advantage of it's inexpensive and it's a rapid test, and you're just screening populations. However, it's not great at diagnosis. So because of the lower sensitivity, somebody comes in who's sick, if they test negative on an antigen, if you've got clinical suspicion, you're probably going to want to send for an in-lab PCR. So great screening tool, maybe not a great tool to use as a diagnostic tool in that regard. Let's see. So what are the uses just in general of testing? Obviously, testing tells us who has the virus at a point in time. It's not an antibody test. Testing is imperative to get answers in who has the virus and potentially spreading it, right? So the quicker you can get that, it's time sensitive, right? The quicker you can get the results, the quicker you can take action. But if there is a delay in results, we want to take action under assumptions, as we've already talked about in contact tracing efforts. So let's see, employers are considering a variety of different strategies. So some are actually doing screening testing, so routine screening, testing portions of a population randomly. Others are testing all before returning to the workplace, and then testing all intermittently. And then many employers are taking the option to just test only those with signs and symptoms in close contacts, and perhaps just having a relationship with a pharmacy or a lab or urgent care or something to be able to have that relationship to get testing quickly and know where to direct your employees if they need to be tested. So it was a lot of information, but we can take questions
David,
here in a bit.
could
Yeah.
you quickly comment? University of Illinois created a saliva test for the students that apparently gives results in 15 or 30 minutes. Could you comment on the saliva testing and how that fits into this?
Yeah, so actually saliva test, nasal swab, all of it fit into all three of these. So well, I don't think there's any antigen that does saliva collection. So we're going to talk actually on the next slide, Larry, about all of the different techniques. So let's talk about collection. So nasopharyngeal was the original swab, right? And that's the one that feels like it goes up into your brain, and unfortunately, in at least one instance, it actually did. There was a case report. But anyways, so nasopharyngeal was the original collection method and still is a collection method, just depending on how the FDA EUA was requested. But the nasopharyngeal swab is the one that goes way back, and it was thought that that's where the highest concentration of the SARS-CoV-2 virus would be. Well, as it turns out, there's actually a high concentration in saliva as well. And so a lot of these assays, these testing procedures, if you will, and how to do a PCR or antigen test, grabbed hold of that and said, all right, we'll just do a saliva specimen collection. So the specimen collection doesn't necessarily, it's not a unique way of testing. It still falls into the PCR molecular. But actually, I'm not sure if there are molecular that collect on saliva. I think most saliva specimens are going to that reverse transcript or going to a lab for PCR. So that's just a collection method. Runs through the same polymerase chain reaction, oropharyngeal as well as the mid-turbinate. Now, mid-turbinate is the nice swab, I'll call it, right? So it just goes into kind of the anterior chamber of the nose, much easier to do, but what studies have found is, hey, mid-turbinate, you're getting just as much virus to be able to run your sample as you would a nasopharyngeal in many instances. So mid-turbinate, saliva, nasopharyngeal, oropharyngeal, all ways of collecting virus on a swab or in a test tube, and then you run it for PCR, essentially. There may be some antigen tests coming out that do offer a saliva specimen, but I'm not aware of those at this point. So how do you do the collection, right? This is an area of confusion. So a lot of vendors were pitching, hey, we've got a home test. It's actually not a home test, it's a home collection. And the saliva specimen is probably the most common one, at least anecdotally from what I've seen, but they also offer mid-turbinate collections that I believe are observed. But you can do at home and just observe on video. So administration of the test or collection of the test, self, right, observed, non-observed, to be a video, or a collection doing the swab. Obviously, if it's a nasopharyngeal, it needs to be collected by a clinician. So location, common ones, drive-through, right? So that's really common. We see that in communities, in pharmacies, in labs, in clinics, obviously, in mobile solutions we've seen, in employer worksite, and then employee home. Test complexity, we'll talk about this just for a minute because you'll read it in the media, you'll hear vendors pitching that. I just want to explain what this means. So CLIA waived means the lab is low complexity. This is your common urgent care lab, primary care doctor lab, on-site clinic lab. CLIA waived means that the test can be done by a medical assistant, nurse, or whatever in a very simple lab without a lot of complex equipment. And this is your point of care testing. This is your rapid antigen testing. This is your rapid molecular testing for virus. CLIA certified is moderate or high complexity. And this means that the lab has to have a lot of built-in infrastructure and support, and that these labs that are CLIA certified moderate high complexity need to be done in a lab. So like a Quest or LabCorp, hospital lab, that sort of thing. So when you look at, oh, this test is coming out, it's going to be CLIA certified or moderate high complexity, you're not going to see that in your doctor's offices. This is going to be a professional lab, if you will. In specimens, this is just kind of where processing occurs, academic labs, so your university institutions, et cetera, commercial labs, and then employer worksite in case of those point of care testing or CLIA waived. So we get a lot of questions around, just gonna look, see how we're doing on time, good. A lot of questions around when's the best time to test and what's this, incubation period. So I created this chart based on some studies that have actually held the test of time. This theory has not changed. Now, this is a general guidance, right? So exposure occurs. When can you test, right? So you've got an employee who was exposed to somebody who had symptoms, and you think maybe he has it or might be getting it. So you want to track, and we know 40 to 50% of people will be asymptomatic. So exposure occurs on day one. Nobody has symptoms because the virus just can't take a hold that quickly, right? So, and this is everybody that we know will test positive at some point. Of people who will test positive within this 14-day incubation period, 0% had symptoms, and 100% of test results were negative, right? Even though we know there's virus that took hold during the exposure because they eventually became sick. But 100% on day one, tests are going to be negative. On day 4, you still run a very high false negative rate with testing, even though we know people will end up at some point testing positive in this 14-day period. At day 5, day 5.1 is actually the median time to develop symptoms. So in people who get sick and they develop symptoms, most people, the median, will develop symptoms at day 5.1 after exposure. And again, this is a general guide, so it's not like, hey, 5.1 days, I'm clear. This is a general guide, and it's the median. But even on that day that symptoms develop, still pretty high false negative rate. And then false negative rate significantly improves. So day of symptoms to 3 days after symptoms, that period of time is when we see the lowest false negative testing results. And again, this is just a guide, but thereafter, day 8, false negative rates then begin to climb. And this is people who we know will test positive. So as you go down this, you kind of lose. So the best time to test is between 5 and 8 days after exposure to get your lowest false negative rate. There's one state, Vermont, who actually took this data and applied it to their quarantine period. So again, quarantine, nobody's sick. Quarantine means they were exposed. We're seeing if they're going to get sick. They go 14 days, right? So that incubation period, that's a long time to wait. What Vermont did, Vermont said, well, hey, we know that false negative rates are best here and that the majority of patients by day 7 will have symptoms. Let's test at day 7, and if they're negative, they can leave quarantine. Now, almost every other state, there's some weird language in some other states, public health guidance, but for the most part, all other states are sticking with the CDC and saying, even if you test negative at day 7, you're still gonna wait it out 14 days. All right, so this I wanted to just mention about rethinking test sensitivity. So you may have seen this in the media. The media kind of took a hold. I just wanted to explain it. So down here you have high analytic sensitivity. So PCR, right? The gold standard. You're sending to the lab and you're testing. They didn't define this duration. This is published in New England Journal of Medicine a couple of weeks ago. So, but because of the expense, because of the time it takes to get results back, you're testing about, I'm just guessing, every week or so. Let's say you're doing that. And this is how you're going to capture. So you've missed this infectious period. Somebody went several days. Now, this actually real time is probably not Not great, but take it with a grain of salt. But you can see if you're testing infrequently, you'll pick somebody up here, but it might even be post-infectious period. Where if you are testing frequently, like say every 3 days, boom, as soon as somebody potentially gets infectious where viral load is super high, again, if sensitivity is lower, but you throw a bunch of virus at the test, it's going to pick it up, right? Well, a bunch of virus typically occurs during the infectious period. This is largely based on I'll call it small case series and scientific theory. So it's not rock solid, but I can tell you it makes sense. And as we see rapid screening with lower sensitivity, i.e. largely antigen testing, available to the market more broadly, we will see more strategy around frequent testing to pick up only those who are really, really hot or infectious in viral load. That's the theory. Testing for antibodies, I'm sure you probably all know this stuff. Seeming we've been at it for a long time now, 7 months. Antibody testing is great to screen a population to get an idea of prevalence, because early on we weren't getting a lot of testing done. We didn't know true prevalence. So it's good for that. But honestly, for an employer at this point, given we're still learning about what immunity means, how long it lasts, I know that there were 2 cases highlighted this week, one in Arizona and one somewhere else around reinfection. Don't panic. I think, the key theory here is, well, we've seen millions and millions and millions of people get infected. How many reinfections have we actually seen? Not many. So the more we kind of have experience in this pandemic, the more confident I am that an immune response is probably really mounting and hopefully is robust and lasts. And it likely has to do with memory B cells and T cells and all these other things, and not just antibodies. So anyways, long story short, for now, antibody tests probably aren't all that useful to do. All right, I'm going to run through vaccine considerations because I want to make sure we have some time to answer some questions. So let's just talk about flu vaccine really quick. Everybody should be getting a flu vaccine. Flu plus COVID will be worrisome, right? So if we're starting to see influenza cases and COVID cases circulate in a community, the combination or getting both at the same time, we know what happens, and it's likely to be bad. You don't want to be one of those people, so get a flu shot. Flu season could be very light, Southern Hemisphere, likely due to mitigation measures around COVID-19, mask wearing, distancing, keeping hands clean, et cetera. All the things that we know also limit flu because they're transmitted very similarly, COVID and influenza. We could see a very light flu season. However, we don't know that because our behaviors in the US are very different than many of the countries in the Southern Hemisphere. So differentiating flu from COVID will be challenged, and I can tell you that my physician friends are already seeing that challenge. We are reaching cold and flu season. We're starting to see symptoms, and when you see somebody, you do a test and they get a negative COVID test, is it a false negative? Well, gosh, I don't know. Should we take extra precautions? Do I treat them for flu? Because even the rapid influenza test runs a sensitivity, it varies, but false negative rates are quite high with influenza. So you can see the conundrum here. Influenza, you have the option to treat with antivirals that are very effective. COVID, we do not. So we'll very likely be seeing widespread use of influenza medications, as well as just confusion on what somebody has. My guidance to employers has been, if somebody's sick, keep them out. In this day and age, somebody's coming in sick, not only do you have to worry about the psychological effects of somebody coughing and sneezing in the workplace or around their coworkers, and they say, oh, I tested negative. It's still going to be a challenge for people. But what if, right? What if it was a false negative? So if people are sick, try to, be smart about it, keep their distance, and really encourage this year employees to stay at home when they're sick. And then influenza can be fatal. Certainly you don't want to mess with influenza. 20 to 50,000 people die from influenza every year. So our Mercer survey, 64% of employers are providing special communications, and 60% will cover flu shots at 100% at, a lot of vendors are doing vouchers this year instead of on-site. So many different options to consider, and your on-site and near-site clinics are probably offering some services as well. Hey, Larry, do you want me to keep going? Should I pause for questions here? Because
yeah, let's get some questions. How many slides do you have left there?
I think 3.
I want you
Going
run
into-
quickly. We'll take questions. We've
Okay.
got about 3 questions here.
Okay. All right. So the COVID-19 vaccine, there are a ton of questions constantly around this. What is a vaccine? I'm not going to go into a whole lot of detail. You can get the slide deck and read through it. But a vaccine basically teaches the body to recognize a unique characteristic of an infectious agent. Commonly, it's surface proteins on a virus, and the COVID virus has these unique spike proteins. And so a COVID-19 vaccine is injected in, and it shows the body what these unique proteins look like. And it does it in a variety of different ways. The traditional vaccine will inject either heat-killed virus that obviously has the proteins on it. That's a very common way, or other viral mechanisms that introduce that existing protein or spike protein that teaches the body to say, look, this is an invader, you want to mount an immune reaction, and the body creates a memory around that. Now, what's unique about COVID-19 vaccines is we're seeing new technology around mRNA vaccines and DNA vaccines. These vaccines are easy to produce, and they get injected, and they teach our own cells how to make these unique proteins. Really, really cool technology, and can keep vaccines less expensive and a quicker turnaround. So how long will a vaccine protect a person? We already talked about the immunology, or how we're still learning about the immune response. Frankly, we just don't know yet, but it is, the more and more I see the literature and see these case series, the more optimistic I get that it is a pretty robust immune response and will last a long time. Now, all these phase 3 trials that are occurring, we're going to be seeing that data hopefully trickle in sooner or later as it's reported. So excited to track and see that. But it is very possible that we will need regular boosters. Is that once a year? Is it every 2 years? Is it potentially every 6 months? We just don't know yet to maintain immunity. The phases of a clinical trial, I actually don't need to go into a whole lot of detail, but just know in the US, for any vaccine to be approved by the FDA, even if it is through EUA or emergency use authorization, it has to go through a phase 3 trial. And there are several different steps. There are many different checks and balances, actually, not just the FDA. So the NIH Data and Safety Monitoring Board, for example, is continually monitoring all of the data that these studies are producing and tracking all of that. So it's not just one board. There are lots of checks and balances in seeing a vaccine approved. In addition, there's so many people, I think, standing on their soapbox, ready to blow a whistle if a vaccine were to be approved too early, that the world would be alerted pretty quickly. So I think we're good. So how will it be distributed? Priority groups first, healthcare workers, first responders, and vulnerable populations. Now, this hasn't all been ironed out yet. ACIP is actually the vaccine authority in the government is creating a little more guidance around this. So we're not quite sure what prioritization will look like, but it will very likely fall to healthcare workers, first responders, and vulnerable populations first. But just some interesting statistics that's going to make this take a little bit longer. So 2 doses, right? 2 doses spread 21 to 28 days apart for most of the vaccine candidates, actually. So it's not just one, you got to get 2, and it has to be the same vaccine. The temperature, -80 degrees, so ultra cold for these mRNA and DNA vaccines, has to be stored. That presents significant logistical challenge. The long story short is we're probably 9 months out before the general population has access to a vaccine. So what should employers be doing? Start to have conversations. So create a subcommittee. I'm sure you've got a COVID-19 committee, task force, right, that you've got put together. pull a subcommittee and say, all right, let's start looking into our vaccination opportunities. So start talking to your vendors and understand, what the carriers are doing, start having those conversations so that if you do have that opportunity to purchase or partner to get those vaccines early, you can then jump on it and offer. I would also recommend that you communicate with your employees and even ask them, would you take a vaccine? We've seen varying polls from only 50% said yes, they would definitely or probably take it, to just more recently 70%. So it's kind of been all over the place a little bit. So start to have those conversations, important to do. Larry, I'll turn it over to you for questions.
Okay, so we've got a couple here, and I'm also going to go around the table. So just a couple quickly. Our local university is using the PCR test to return exposed folks back to work 4 days after their exposure. If you have someone who's had a potential exposure, is it appropriate to use the PCR test to return asymptomatic folks back to work if they've not converted after 4 days?
So you saw that chart. I would say the best evidence says no, that's too early. 4 days false positivity rate is quite high. Like I had said, only one state actually took that science so I had created kind of that timeline based on the best studies or evidence that we have, which aren't great, but they're reasonable. Vermont is the only state that took that and said people can test out of quarantine after exposure, right? But that's at day 7 when we know that false negative rate is lowest. 4 days, unless there's some other data out there that I'm not aware of, that's too early in my opinion. But maybe there's some other study or data that they have that I'm not aware of at this point.
Okay, we're beginning to hear of a combination flu COVID test for the fall. Do you have any information about this? And is this something clinics should use?
Yes, yeah. So I mentioned, COVID and flu have very similar, both have influenza-like illnesses or ILIs, what we call it in the healthcare world, very, very similar. And as a clinician, it would be impossible just to be able to tell the difference unless there was a pathognomonic or a unique physical finding or symptoms, such as you can't smell and you can't taste. That's probably much more likely COVID. Flu doesn't cause that, right? So if there's nothing like that, then yes, absolutely, you're going to have to do 2 tests. But instead of doing 2 swabs, doing a nasal swab for influenza and then doing a nasal swab or saliva or some other sample for COVID, there are kits that are coming out. In fact, the list of EUA, the list of dual tests or combination flu and COVID tests that are waiting EUA, I understand is quite high. So we should see a pretty significant influx of those tests available, hopefully soon. Now, very likely, though, it will be a single swab collection and then send to the lab. I don't know that we'll see a point of care. Maybe we will, but I don't know yet.
Okay, so I'm going to go around the table and invite people to talk. Aggie Lunn, do you have a question or comment you'd like to make? Aggie?
No, sorry, that's a mistake. Sorry.
Okay.
Great talk, though. Thank you very much.
Sure. Anoop, question? No? Okay. Courtney Young, do you have a question or comment? Okay.
I do not, thank you.
Okay. Debbie Heath, Debbie, any comment or question? Yeah. Okay. Deanna Hall, any other comment or question? Okay. Dar Harwood, any comment or question?
Nope.
Okay. Rebecca Bergner, any comment or question? Rebecca?
Nope, sorry about that. Thanks for the information.
No problem. And Thea Lynn, any comment or question you have? No? Okay, we have a question. What lessons around benefit designs, safety measures, emergency, et cetera, can employers learn from COVID in 2020 that could be deployed urgently if we have another pandemic?
Wow, there's a lot there. There's a lot of lessons learned. I can tell you that this experience has been a wild learning experience for, I think, all of us, right? And having the opportunity to work with many different employers on many different strategies and lessons learned as we kind of work through this pandemic and as all of it changes with new information. I guess some of the key lessons learned. One would be flexible because information is going to change, right? We have seen from the very beginning a constant as we learn more about not only this virus, but about, what public health is capable of and what the hospitals are capable of and, what on-site, near-site clinics are capable of. It has been a quick shift. So one, be flexible. Two, that also ties to be flexible with your employees. So some of the best practices we've seen around benefit structure have just been a shift or redesign to support time out of the office, right, when it's needed, expanding sick leave, that sort of thing to a reasonable degree. And I'm sure if you are all HR specialists, you're very well versed in all of this. I think for this group, continue to partner with your on-site or near-site clinic vendors because they are constantly learning as well, and information is constantly shifting and changing. And so, really, that collaborative effort in meeting the medical needs and just in general support is really, really important. So, keeping in touch with that team as well and having regular meetings.
Okay, last question. When someone is tested due to symptoms and comes back negative, what's the best way to bring them back prior to 10 days?
So if they have symptoms and they test negative, so if there is high clinical suspicion, so this really needs to come from a clinician, right? If somebody has fever, chills, that sort of thing, and they test negative, it would be a good idea to test them again, right? Especially if they have a strong history of, I was exposed or I was in a high-risk activity. I hung out in restaurants all weekend when I was in Sonoma, whatever it is, right? So the physician has to, or the advanced practitioner has to consider all the different pieces and decide what is the clinical suspicion and do we test them again. And so if somebody tests negative, but they had pretty significant symptoms, you might as an employer say, well, gosh, did you really work with your provider? Are they still concerned? Because we know that there's a potential for false negative test results and we don't want to bring you back if you're that sick. But this also ties, Larry, to the advice that, hey, if somebody's sick at work, be really conservative. If an employee is sick, be really conservative in bringing them back. Just have them stay out if they can, right? Because it might be influenza. You don't want that to come in. It could be common cold or rotavirus or whatever it is. You don't want them to bring it in. Just be conservative. If they can stay out, great. If not, make sure if they tested negative, mask, distancing, all of those things that we know can help as well.
All right, and last question. There's a number of vaccine manufacturers that are coming close to production or at least final approval. How do you know which one to order? I mean, will they all be on the market and each clinic and each employer will decide which one it wants? Or what will the marketplace look like? Is this a competition or is it like there's 4 asthmatic drugs and you can pick whichever one you want? How's that going to work?
Yeah, so this is my own suspicion because it's too early to tell, but I suspect that you won't have a choice, right? So the prioritization, because it has to be the same vaccine, prioritization will be one, the first brand or two that comes out, and then that's pretty much for that group. And then the next one gets approved, and maybe it's in phase 2. You will not likely have a choice of 4 vaccines, at least not in 2021. In 2022, there may be a choice, and we might say, hey, the Moderna RNA is the best, and it has the most efficacy and is the safest, and whatever it is. So down the road. But I think in 2021, the first round, there will probably be very little choice.
Okay. Well, thank you very much, David. Appreciate you taking the time. Thank you, everyone, for being on the call. If you have questions, please send them to me, and I'll make sure David gets them, and we'll get them back to you. A copy of the slides and the recording will be made available to everyone. So I want to thank everyone for participating. And David, again, stay safe. Everyone, stay safe. And let's hope the vaccine comes out quickly, and look forward to the next program. NAWHC will have a session on the best practices in musculoskeletal and pain management on December 9th. It will be a virtual program. We hope you can participate then. Again, everyone stay safe. Have a good week. Bye-bye.
Thanks, Larry. Thanks, everybody.